Hi, so this is the second video in the formulation and sort of thinking about care planning with young people. It's probably helpful at this point to refer to a case and come back and have a conversation about how we might use the principles that we talked about in the first video.
Hi, my name is Laura, and I've just turned 14. My mum brought me here today because I haven't been going to school and I don't really see my friends much anymore. My dad doesn't really think I should be here because he doesn't really believe in this stuff. My parents fight a lot, and they fight a lot about the fact that I don't go to school. But the thing is that I get really bullied at school, and the kids at school make such a big deal of my family like not being from here because I'm the only one with Italian parents at my school. At nighttime, I take a long time to get to sleep because I'm worrying a lot about school the next day, I suppose, and I don't know, I just think too much. I can't switch off. And so when I get stressed at nighttime, I just go on Facebook on my phone, and then I fall asleep late, and I suppose I just end up sleeping in the morning. And then by the time I wake up, it's just, I don't want to be late to school and have to walk in front of everyone. I suppose I want to be here because I'm really sick of fighting with my parents about it, and I'm sick of them fighting, and I don't really want to fail school either.
One of the things I guess that can be useful is to think about the 5Ps. In my head I have like a little table with each presenting problem, predisposing factors, and think about what the young person and perhaps their family has talked to you about in the conversation and how they might fit. So I guess the presenting problem for Laura in this case is that she's not able to get out of bed and go to school. That's distressing her. She's talking about that. She's also talking about the experiences at school, and she's talking about how the sort of cycle of things is happening at home and there's family conflict. So what I heard in her story is that the most pressing things for her are the family conflict, the bullying at school, not being able to get to school, and they're the reasons that she thinks she's here. I'm happy with that in terms of I'd probably include some symptoms about, some mixed mood and anxiety symptoms, sleep deprivation or interrupted sleep, ruminations, etc. in my presenting problems, and talk to her about as a way of kind of beginning psychoeducation about how I think these life events and symptoms fit together. I guess the predisposing stuff that we've heard in Laura's story is her perhaps thinking about her experience of how she's grown up in terms of some of perhaps she's talked a bit about the care she's received or felt that she hasn't received, or how that's been delivered to her. And I guess I try and formulate that in a really strengths-based way and experiential way that's non-family blaming, but also recognising that she can have an experience of something that's not necessarily matched with her parents' intentions. So yeah, there's some of the things I'd be beginning to think overtly with her out loud, talking through. So you came for these reasons. This has kind of happened on a background of some conflict in your family, or you've experienced this from your parents. Is that right? And then perpetuating, so making things this worse for you day to day are things like you're worried about going to school because of the bullying. That means you go to sleep really late, and maybe the quality of your sleep's not that great. That means you can't get out of bed. Then you have family conflict. Is that right? Is that how we're thinking about how these things relate to each other? Because you then beginning to perhaps, hopefully naturally, point towards what you then might do together about these problems. So I guess in a written form, or even how you might discuss these things in clinical review, it would come together as something like, Laura presents as a 14-year-old young woman with some mixed mood and anxiety symptoms. I usually list in the written form. I would list the symptoms, and she presents with school refusal on the background of bullying. This has escalated conflict in the family home. This occurs on a background of, and then the predisposing, and then the prose narrative, I guess, is summarising all of the factors coming together. In the practice principle for formulation, we've got a table which lists the 5 Ps down the side and helps you draw them out, and then an example of how you might put that together in a prose form. So it's really worth having a good look at how that's come together as what the written formulation might look like. So I guess having pulled together all the 5P factors in a table and beginning and prose formulation, we're also really keen to incorporate protective factors and the contextual factors of family, and thinking about how you would bring that all together to talk to Laura about what you would recommend and if that makes sense to her based on what you've jointly come to understand about how she is struggling right here and right now. So in her case, she's done a great job coming along and has, you believe that she's engaged with you well in the session, has been able to open up. It's not an easy thing for young people to do that. Whilst we can forget that every day, it's a really important strength to highlight. And contextually, her and her family, in particular mum, have got locked in this battle about the getting out of bed. And so some family work focusing on, how might that get unlocked, as well as perhaps some skill building around the anxiety symptoms, so some relaxation, some breathing techniques, etc., particularly to reduce the ruminations in the evening. Bit of sleep hygiene work to perhaps get the Facebook and the screens out of her room at night, and also then some CBT on gradually getting back to school with a little bit of increased sort of managing the distress each day, and working, probably contextually also working with the school around what that might look like. So that would be how I would be thinking about the formulation and the treatment plan for Laura as she's presenting at age 14. And it's useful to read an example of a reasonable, good enough written formulation in the practice principle about Laura. So the practice principles on formulation, including this particular case example and formulation, are included on the course page. So we're going to keep exploring formulating by coming back to Laura. So Laura's going to come back to us at the age of 16, 2 years down the track, with a slightly different presentation, and we'll come back and talk about how we would then formulate that again with her.
Hey, I'm Laura and I'm 16 years old. I came here for an appointment a few months ago because of my depression. My depression basically looks like me being really angry and moody all the time, and I've been crying like a lot, which is really annoying. Also, I've been fighting with my parents heaps and I've been losing a lot of weight. I've been losing the weight because I've been on these new diets, but mum's been nagging me to eat more, which is frustrating. Oh, and my boyfriend broke up with me because he said I was too moody, so that sucked as well. When I feel really down, I sometimes cut myself or try to punish myself somehow, but that usually makes me feel a bit better. I've been seeing a therapist and I actually really like going to therapy, but mum doesn't think it's helping me. She wants me to go on those antidepressant type drugs, but I don't really want to because it freaks me out what they might do to my brain and stuff. And also, I'm actually getting better already, just mum doesn't see that. I'm happy for mum to come in and talk to you now if you like.
So as you heard, this time Laura's presenting, and perhaps she's not that concerned, but certainly mum is concerned about some weight loss, but she's notably more kind of labile in her mood, so she's irritable sometimes, tearful, angry, and these things are changing quite quickly for her, and that's uncomfortable. And while she may not have described it in that way, certainly that would be something I'm checking. So you're having some big mood changes and it's moving from one thing to another really fast, and how is that for you? it's often a pretty uncomfortable experience for young people. So that would be a part of what I would be thinking about as her presenting difficulty. She's again in frequent conflict with her family and is less engaging in social interaction. So her focus is perhaps around, again, the family conflict and the social stuff, but I would again be pulling in the things that I think are part of how she's presenting now that are difficult for her. Sorry, predisposing would probably be somewhat similar to when she was 14, but we might include the previous treatment in terms of, you know, she's had a background of CBT, she responded well to the CBT or didn't, depending on how you would formulate that she's got a history of some mood difficulty. So this is an exacerbation of that, or a slightly altered presentation of her mood symptoms. So in terms of precipitating factors, a really significant shift this time for her because she's had her first relationship and her first relationship breakup. Literature is really clear that this is a common trigger for mood problems, and given her background of mood difficulties, this is something I would be thinking about pretty seriously, and recognising to her that's a really significant life event. You know, there's a lot of literature around clinicians needing to remember to take very seriously early relationships for young people, and particularly early breakups. It's often one of the most profound experiences they can go through, that first heartbreak. So, you know, there's some kind of validating and you can do within the formulation about that's a really tricky experience, and no wonder you're feeling a bit all over the place. And I guess perpetuating this is some of the symptoms. The dietary stuff has an interaction with mood. She's started self-harming. So I guess what we're starting to think about is the strategies she's adopted, whilst understandable in terms of whatever people do to manage their feeling is a reasonable crack at doing that. Often they're not choices that help them recover through those symptoms. So I'd be starting to have those conversations with her. You know, do you think your mood, your weight loss and your diet is affecting your mood? How does the self-harm feel for you? And start to explore how that factors into perpetuating some of these difficulties. Again, from a strengths-based perspective, we'd be coming back to protective factors and thinking about that she's come back, she's help-seeking, perhaps she responded well to the treatment in the first case, she's still got a good relationship with GP, she's mum's involved and has participated appropriately in the treatment before. So again, you can check out the practice principle, which has a good written formulation, but we would slightly reconceptualise it. In this time, Laura's a 16-year-old young woman presenting following her first relationship breakup, on a background of some mood and anxiety symptoms and some difficulty in the family managing those, but responded well to treatment in the first case. And again, probably I would be looking at a cognitive and behavioural intervention, particularly if it worked well the first time, looking back at her relapse prevention plan where you ended off. But the important thing is thinking about a joint understanding, bringing all the 5 Ps together and it guiding the treatment plan, and that making sense to the young person, because that's really a big part of psychoeducation. So now that brings to a close the video on formulation, and it's really useful in your teams at your centres to look at the practice principles and read each other's written formulations, use them verbally in clinical review meetings, and really they're good ways of refining and practicing your formulation skills. So thanks for watching.